Taimi, you presented your story on how diet and nutrition helped beat your depression, but you followed on from Helen Lockett.
Yeah, that's right. I mean, I really wanted it to be very responsive, because equally well to the general public seems like one of those kind of high strategic plans that the health services are all part of and signing on to, and sounds like a good idea. But in terms of what that relates to in terms of a story or how people are experiencing that 25-year and why, loss of life, really, that's what it is, I thought I'd tie some of those strings together. So as Helen was talking, I was taking a few notes about what she was trying to address, and then I sort of gave some personal stories, both from myself and the people I knew, that kind of really highlighted some of those issues that Helen was talking about. I mean, the reason we die 25 years earlier isn't what people would think of when they think of mental health. It's not through suicide. It's not through, mental health conditions themselves. It's through those physical ailments. And generally it's through this medical overshadowing, which means is if you've got a mental health condition, then the physical stuff isn't picked up. It's not, it's kind of, the biggest thing that we're dealing with is the mental health issue. So that's the stuff that comes to the forefront. So everything else is either put down as a symptom of that mental health condition or just really isn't taken as seriously as it would, like you said, if a housewife or the All Black walked in and said to your GP, I've got a sore tummy, Having that psychological, disability, I'm using my bunny's ears now, means that we are more likely to experience physical things that have those symptoms. For example, I think, if you're ever diagnosed with, she pointed out, it was colorectal cancer or breast cancer, and you have a mental health condition, you are more likely to die. It's just, that's the statistics, and the graph she put on the screen was alarming. It was really, really frightening. Is that because
we're seen to have less resistance to be able to fight or address those sorts of cancers?
It's very interesting, and I think there's a lot of emerging science. I mean, I can talk about some theories that are going around. I don't think there's enough evidence to say this is definitely what causes it, but certainly I'm following along those theories that relate a lot of these physical issues, including cancers and autoimmune conditions and things like that, with an increase in inflammation in the body. And if you look at kind of the types of studies that are currently being run to connect those dots together, it makes a lot of sense. I mean, when your body attacks itself, you get an inflammatory response. So that's why you get pain. Yeah, so whether it's a migraine or you talked about arthritis, whether it's your joint pain and things swell up, it's an inflammatory response. It's the body's way, of trying to get rid of the stuff that isn't meant to be there. The difficulty with an inflammatory response is that when your organs and your joints are inflamed, one of the biggest organs is obviously the brain. But we don't look at the brain in psychiatry and psychology. If you go in with a heart condition, they'll take an X-ray of your heart, or if you go in with a tummy ache and you don't have a mental health condition, they will do stick something up and have a look around with the camera, but we don't take MRIs of the brain as like a standard thing when people come in with a health condition, and yet we know that when inflammation is hitting other parts of the body, your brain inflames as well. And if that's kind of pressing up on the skull on the inside, is it any wonder you're getting mental health symptoms with that as well?
What about what did Helen say, and what's your understanding of the impact of psychiatric medication? Because it's I got very excited about this Equally Well campaign and interviewed Helen Lockett on Take It From Us, and went to a day-long conference in Wellington, and it seemed to really have some impact and some momentum, this Equally Well. I know that it is there, it's still got a profile, but I wonder whether it's getting the impact and the influence on the government. But firstly, the question really, what impact does our psychiatric medication have on the length of how long we live?
I think there's plenty of studies out there to say that psychotropic medication has a detrimental impact to our life in terms of its length. and you don't really need to even pinpoint what that medication is, but the fact, I mean, the very easy fact that things like psychotropic medication increase the stress on your heart, increases the metabolic syndromes, so you're more likely to get things like diabetes, you're more likely to put on a lot of weight, so there's obesity challenges that happen with that. There's more challenges with the liver and kidneys. I mean, I know with a good friend of mine who's recently gone through cancer, is a mental health consumer. He was saying that he wasn't able to get chemotherapy because the damage that the psychotropic medication had done to his liver and kidneys means that the chemotherapy might have killed him, so he couldn't get the therapy he needed to.
It's a small world, because I think I know who you're talking about. I'm not going to name that person,
right.
But I mean, and we don't want to scare any of our listeners about psychiatric medication, but I guess it is definitely a reality, and I think one of the facts is that so much of this medication does put weight on, and then it makes us more difficult to get around, to exercise, to play sport or whatever.
Yeah, and let's face it, if you put on a heap of weight, you're going to feel more depressed, not less, aren't you?
Well, yes, exactly.
Yeah, but I mean, it was interesting because I was... I mean, I can't talk about too much about what we discussed yesterday, but I spent the entire day with the Ministry of Health yesterday looking at our Mental Health Act, and whilst changing legislation takes about 10 years, it was about what we could do within the current legislation to try and help some of that stuff. And medication came up time and time again, in the sense that under the Act you get two choices. You get medication and hospitalisation, that's about it. And so what is it that we could do, regardless of what government happens next, is what is it that we could do to free up some of that choice within the Act, some other things you can do. And one of the things that I highlighted, along with a few other people around that table, is that there is no program in New Zealand to support clinicians and mental health consumers to wean, taper, reduce, or, the medications, if that's one of the choices that they make. Pretty much if you say, I'd like to taper, I'd like to reduce my medication, I'd like to try other things, the fact that we live in this risk-averse society means that if you want to do that, you're on your own. And I think we have a responsibility to try and set up some support, whether it's groups or some work or some research about how to help both clinicians and their clients say that this doesn't have to be you don't have to be on medication for a long term. It certainly can help, but we need to kind of get those other psychosocial stuff right as well, so that you don't have to be on it long term.
I mean, I think that psychiatrists have to be very careful when they say about their patients that this patient needs to be on antidepressants or some form of psychiatric medication for the rest of their lives.
Yeah.
Now, I saw my GP about 2 or 3 weeks ago, and he is fully aware, because I have told him that I am tapering off my medication down to 3 a week, a very low dose. But he quietly reminded me just before I left that, you're a psychiatrist, which would have been probably, haven't seen a psychiatrist for 15 years.
Yeah.
He said in the notes that I should always be on antidepressants for the rest of my life. Well, how do we get rid of that legacy?
Yeah.
There's no acceptance that my lifestyle has changed, my work has changed, the pressures on me have changed.
Yeah.
I have taken up mindfulness and made a commitment to do that every day in the mornings for 30 minutes. And I guess my GP recognises this, but as you say, the medical profession is risk-averse and they want to cover their butts.
Well, let's be fair to the medical profession here. It's not the medical profession that's risk-averse. It's our society that's risk-averse. So I think in order to turn that around, there's a couple of things that need to be done. One is we need, whatever we do to reduce that risk averse, we need a really concerted and and alongside campaign for the public to understand that the risks really aren't as great as the media make it out to be. We need to be talking to the media and helping them understand that, you know, the impact of some of those headlines of the 1% risk that they put out makes people think that that's the majority, not the minority. And we need to... I mean, one of the biggest things that creates this risk-averse society is that when things go wrong, so someone dies in mental health care, is that we shoot the responsible clinicians, don't we? We blame them for not, you know, or the mental health services for not keeping that person safe. And I can understand from a family perspective how devastating that is when you've asked for help, you've got help, you've put someone in hospital, you think they're safe, and then they die anyway. So it's a tragic consequence. And then what happens is that family, quite rightly, will go and ask for an inquiry. And then that's a very traumatic experience for the family and for the staff itself. The difficulty that then happens after that is that the culture of mental health services becomes more risk-averse and more coercive in their practice. So we need to go right back.
It also keeps the profile of this particular case
in
right
the news.
Up there in front of the public.
That's right. So I think in order to get around that, we need to go right back to what's important. And I think one of the things that we don't do very well at the moment that we could improve almost overnight is our working very closely with families at the very beginning of someone becoming unwell. I think that sometimes they're brought in too late into the process, they don't know what's going on, they're worried for their family, but we need to learn together how to share that risk with support so that clinicians, the tangata whai ora themselves and the family can go, what are the real risks here and how are we going to manage this together, rather than it being all responsible on one party, i.e. the clinician. And if we can do that right from the very beginning, and we can look at all the psychosocial factors and, you know, whether we use Te Whare Tapawhā or something like that as a base for looking at, you know, someone holistically, then it's giving somebody more autonomy, it's giving the family real validation that their role is really important and that they can help in that role. They can be part of what we call in mental health services the multidisciplinary team. It doesn't have to be a clinical team. And then it stops that stuff later on down the line of it being a reactive response.
Yeah, I guess that's a lovely thing to hear, but of course there is still quite a bit of stigma and discrimination and ignorance among families themselves.
That's right. Yeah, and that's why we need to open our descriptive terms of what family is. You know, it doesn't have to be related to by blood. You know, your whānau are the people you choose to be around you that you think are going to be supportive in that process. And I think the other thing, one of the things that we highlighted yesterday is that if families say no because it's too challenging in that beginning part, you know, they've obviously at this stage in, you know, our society's lives with mental health services, people usually come into it at crisis. We'd like to change that, but that's generally how people... So the families are already burnt out by that point. And if we ask them at that point, do you want to be involved in their care? Of course they're going to say no, because it's too tiring, too exhausting. But what we need to do from that point is keep asking them. Keep asking them, do you want to be involved? You know, a few days down the line, a few weeks down the line, a few months down the line, would you like, you know, keep giving them the opportunity.
Who do you think needs to ask that question? I mean, if the person is in respite or in psychiatric care.
Yeah. Whoever their care team is, including themselves. Now, when I speak of a care team or an MDT, I'm now inclusive of the cultural support, the peer support, the person themselves and the family. I'm not just talking about clinicians.
You've indicated that you were at a meeting recently with the Ministry of Health talking about the Mental Health Act. Obviously, that's a controversial part of our mental health system, and the whole compulsory treatment orders, the community treatment orders. It does suggest that parts of our mental health care are still way back in the dark ages.
Yeah, they are. And I mean, I think we need to keep in mind that we will only ever hear the bad stories, because they're the things that need to be changed, and we do need to hear those stories. But one of the things that really not surprised me at all, but kind of made me feel really good, is the pockets of work around the country that are incredibly innovative and incredibly inclusive. And it's not the work isn't being done. I think the challenge is, how do we at the moment, things tend to be funded for pilots. They tend to be funded to see, is this going to work? And then if it does work, we don't have the funding capacity or sources to keep those things going, or to learn from them and implement them across the country. So I'm sorry to hear that, the person that you spoke to had difficulty with inpatient peer support acute services, because I've only ever heard good stories about that. But I also know that look, you hear it every single day in the media now. Our mental health services are stretched. We had the government say that they put an extra $300 million into our mental health services, which is fantastic. But actually, that's a 20% increase, and our stretch on our capacity is increased by 60%. So, well,
that's $300 million. I mean, that's somewhat historic. It hasn't happened just in the last few days, few weeks, or whatever.
No, that's right. It happened a few years ago. Yeah.
And Jonathan Coleman, the Minister of Health, that seems to be his traditional response to any criticism of the service. Surely this service is about responsiveness. It's about people in crisis. It's about this person that I met, last week. Yeah. When he's suicidal, he's got young children, he's got a wife who's very caring. Yeah. His mother has recently died, and he's got family issues around inheritance. He needs help.
Yeah.
And I mean, it was great that the crisis team was called in and he got to a respite, an acute respite service.
We're only dealing in a crisis response. And Dr. David Kadaya said yesterday that I really responded to is that we need to find a way to get to a system where we don't, as mental health services, have a minimum criteria for you to get in. Because our criteria is, it's up to the roof now. You have to be in serious crisis to get help from us. We need to put that power back in the person's hands and say, if you need help, regardless of whether you've got a diagnosis or whatever it is, you need help, you need to get it. You need to be the master of saying, I'm struggling right now, I need help, and we need to find a way of providing that help. Now, whether that works in primary care, and I know that part of Labor's policy that they released last week is just that they're looking at primary care being that main source, and it's nice that we've got one party that's started to put publicly out what their policies are going to be coming up to the election. One of the things that I'm working on with Platform Trust, which is a kind of the umbrella organisation for a lot of NGOs, is a campaign that we'll be releasing in the next couple of months leading up to the election, called It Matters. So it'll be #ItMatters. And it'll be an online campaign and an advertising campaign just asking the public to tell their politicians, regardless of who they're going to vote for. We don't really care who people vote for, but we want every single political party to put mental health policy as first priority on their agenda. And we'd like New Zealand to stand up and say, it matters.
The housing issue is pretty urgent, isn't it?
Yeah.
There was a story out of Queenstown where doesn't matter whether he was Australian or Kiwi, he was an Australian, and he built himself a hut in somebody's macrocarpentry, and he was living up there. Living up there, and the owner came along and thought, he can't get rid of this guy, he cut the tree down.
Yeah. And of course, and then there was something on the news very recently, that was talking about a house that everybody knew was a pea house, just going for a ridiculous amount of money. It's like that the entire house will have to be gutted, but it's a real indication that the people don't have anywhere to live.
So it was for sale or for rent?
For sale.
For sale, yeah. Yeah, so getting back to the address that you gave with Helen Lockett of the Equally Well campaign, you were presenting your story on how diet and nutrition helped you beat depression, and I must say, I think you're looking as well as I've seen you for a long time. You look as though you're transformed. Well,
it's interesting because I've had quite a bit of tragedy surrounding me in the last couple of weeks. So I think that my resilience is showing in the face of adversity, I guess. And certainly diet and nutrition was a big part of my recovery and a big part of my life going forward. And for me, it did relate very much to that physical stuff. And if I was reflecting on what Helen was saying in terms of people not being able to access all that overshadowing stuff that we breached on, and there were a couple of stories I had around that,
Sorry, can I just clarify overshadowing?
So overshadowing is when physical symptoms or physical ailments or chronic illness is not picked up by the medical profession because their mental health symptoms seem to overshadow that, or their physical symptoms are put down to mental health symptoms. And so a very good example of that is a colleague of mine only about 5 years ago. She found out that she had cancer 2 weeks before she died. And the real tragedy of that is that she went to her GP 18 months prior to say that she had a stomach ache. And because she had a history of a delusion that she was pregnant, the medical professional in that case just assumes that it was part of what she was dealing with her mental health issues, and didn't look into it like if someone without those issues had come into the office.
Well, to focus on thank you for that story, but it looks to me, and seeing you today, that diet and nutrition is definitely having a very positive impact. And you mentioned this word resilience, which of course is so important in our mental health, isn't it? Have you learned a bit more about resilience in your life?
Yeah, absolutely. I'm much more balanced. I mean, my life is far more hectic and is far more busy than it ever has been in its life. I mean, my day yesterday started at 5 a.m. and finished at 10 p.m. and yet I'm here this morning. And I think certainly, what I eat makes an enormous difference in terms of how I can manage my energy throughout the day, how I can make sure I'm getting the right nutrients for my brain to continue working for a 14-hour day.